So, good evening. From today, we are going to start with the new series for kidney physiology, and today is the first series for that. So, before starting that, let me tell you about the Plus subscription. You know already about this, that we are having daily live classes, structured courses, live test, as well as unlimited access are there. In the Iconic subscription, we know we are having both of Unacademy as well as Prep Ladder. And these are the courses which are running recently from 15th of July, and they are the integrated clinical batch. So many like medicine radio, medicine micro, pathopharma, like this they are integrated, and they are the clinical batch, and this is for the focus FMG batch. So a lot of batch courses are running, so those who are in the academy can join these classes. And these are the various offer. We are launching 2-month subscription for only this much, and the code for joining is Physio10. If you want your maximum discount, it is Physio10. Now starting with the kidney physiology, just a minute. Okay, so from today onward we will be discussing there will be so many series of that, in which we will be discussing the kidney. Yes, YC MCQ discussion or topics. So initially we will start with the topics, and after finishing the theory we can start with the MCQ also. Okay, so let me start that the basic unit of kidney is nephron, and there are mainly two types of nephron as we know. One is called as cortical nephron, mostly in the cortex, other in the juxta medullary nephron. So the purpose of these series will be to discuss the clinical aspect of the neprophysiology. As we know, the questions which are asked in kidney nowadays are most of them are clinical. Okay, so there are two types of nephron. We know the basic unit of kidney is nephron. The basic unit of kidney is nephron. Okay, and there are mainly two types of nephron, cortical and juxta medullary nephron. If we look into the kidney, the outer is called as cortex and inner is called as medulla. So this one is cortex, then it is outer medulla, and this is called as inner medulla. So the one nephron which is starting from the cortex but never going beyond the outer medulla, for example like this, these nephrons are called as cortical nephron, and those nephron who go very deep inside the inner medulla, these are called as juxta medullary nephron. So basically nephron can be of two type. Good evening, Achan, Nitesh, everyone. So these are called as cortical nephron, these are called as juxta medullary nephron, and they are maximum around 85% of all the nephrons are cortical, only 15% are juxta medullary nephron. So you know that most of the blood is in the cortex. In the medulla there is a scarcity of the blood to maintain the corticomedullary gradient. So because they have most of the blood, you can write down more blood supply is in the cortical nephron. There is more blood supply in the cortical nephron. So main function of cortical will be, excretion of the waste. Excretion of the waste. So there are two types of nephron. The cortical nephron has a lot of blood supply, and the main function is excretion of the waste. On other hand, juxtamedullary have comparatively, you can say, less blood supply. Okay, and the main function is concentration of the urine. Concentration of the urine. So physiologically, anatomically, in both manner they are different. Cortical being more in the superficial area of the kidney, having more blood supply, more PO2 also. PO2 is 50 here and PO2 here is only 15. So we can see the more blood supply is in the cortical and function is excretion of the waste. Now in the whole series I will be discussing, like for example, if I start with the glomerulus, so I will discuss everything about glomerulus. Then I will start with the PCT and we will discuss everything about PCT. So like this we will start with the one segment and cover the whole aspect of that. Okay. So starting with the glomerulus. What is glomerulus? Okay. If we look into the glomerulus, you know, this is your, how long class? This will be 1 hour class. This is your Bowman's capsule. This is your Bowman's capsule. This is your efferent arteriole and efferent arteriole. Efferent arteriole, good evening, and efferent arteriole, these are your endothelial cell. These are your endothelial cell of efferent arteriole and efferent arteriole, and these endothelial cells, these are blind or they are fenestrated? What do you think? They are actually fenestrated endothelial cell. So the first layer of the glomerulus is fenestrated endothelial cell. Fenestrated endo. So the first layer is fenestrated endothelial layer or the cell. And what is the size of fenestration? What is the size of the fenestration? You know, these are fenestrated and size is 70 to 90 nanometer. Size of the fenestration is 70 to 90 nanometer, so that so many things can be filtered. And after that the second layer is of the basement membrane. This layer is second layer and this layer is called as basement membrane. So basement membrane is formed of what? Basement membrane is formed of what? Number one is collagen. Which collagen? Type 1, type 2, type 3, type 4. Which collagen? Yes, it is type 4 collagen. Very good. It's type 4 collagen. First component is type 4 collagen. Number one. Yes. What else? Second is laminin. Laminin. Second component of your basement membrane is laminin. Third is heparin sulfate. Third is heparin sulfate. All these has been asked in your examination. Now, if there is mutation of type 4 collagen, what it will cause? If there is mutation of type 4 collagen, it will cause a disease, Alport syndrome. Yes, it will cause a disease, Alport syndrome. And type 4 collagen is not only in the kidney, but there are other locations as well in which you can get type 4 collagen. So one is of course your glomerular basement membrane, second is your lens of the eye, and third is cochlea. So because there is mutation of these product, collagen, so because of GBM there might be hematuria. Patient might have what? Yes, please. Yes, very good. Hematuria, blood in the urine. Because of the lens, patient can have lens dislocation of the lens, and because they are also in the cochlea, and if it is not working properly, there can be sensorineural hearing loss or nerve deafness. So these can be the feature of Alport syndrome because of mutation of type 4 collagen, which is the component of basement membrane, not only in the GBM but also in the lens as well as cochlea. Now, third layer is your visceral epithelial cell. Third layer is which one? It is called as visceral epithelial cell, or simply we say podocyte. So what is the third layer made up of? Third layer is made up of visceral epithelial layer. It is called as, let me write it separately here. Third layer is called as visceral epithelial. These are visceral epithelial cells. What are these? These are podocyte or visceral epithelial cells. Okay. Now, this glomerular basement membrane is formed of what? Who is forming this glomerular basement membrane? It is visceral epithelial cell. So the first function of visceral epithelial cell is to form. The first function is it causes synthesis of the GBM component. And number 2 point to be remembered here is that loss of podocyte. What are the disease in which loss of podocyte is seen very frequently? Loss of podocytes is seen in number 1, focal segmental glomerulosclerosis and diabetic nephropathy. Very good. Diabetic nephropathy. Okay. Now this visceral epithelial cells are very important because you know if this is your epithelial cell. Okay. What is this called as? This is called as filtration slit or slit diaphragm. This is called as filtration slit or slit diaphragm. From where a lot of things filtered. Question number 1 is, what is the size of filtration slit? What is the size of this filtration slit or slit diaphragm? And answer is, it is 20 to 30 nanometer. It is 20 to 30 nanometer, number 1. Number 2 question is, what are the proteins that are forming this slit diaphragm? What are the proteins? What are the proteins which are forming this slit diaphragm? And what will happen if there is mutation of these protein? Protein number 1 is, yes, nephrin. Very good. Protein number 1 is nephrin. And for that, NPHS1 gene is involved. NPHS1 gene is involved, and if there is mutation of NPHS1 gene, what it will cause? If there is mutation of NPHS gene, it will cause a disease. Yes, please. Congenital nephrotic syndrome. It can cause a disease, congenital nephrotic syndrome, or we also say it of Finnish type. It is also called as of finish type. Minimum change nephrotic syndrome because of mutation of gene NPHS1. Similarly, we have second protein called as podocin. Okay, and this is because of gene called as NPHS2, and the mutation in this protein will cause what? What will happen due to mutation of this protein? Yes, please. Anyone? Steroid resistant nephrotic syndrome. And the third, what about the third? Third is alpha actinin 4. What is the third one? If there is mutation of alpha actinin 4, what it will cause? It cause autosomal dominant focal segmental glomerulosclerosis. There are so many proteins, not only 3. There is a list of proteins which is forming filtration slit, but these are clinically important and asked in your examination. So minimum you must remember these proteins, so that we can now discuss. This was the anatomy of the glomerulus. Till now we have discussed only the anatomy of glomerulus. Now I will discuss physiology of GFR, glomerular filtration rate. Okay, like GFR is what? The formula for GFR is filtration coefficient into net filtration pressure. Net filtration pressure. If I make so question number 1, KF can be measured directly or indirectly. There was an MCQ that this filtration coefficient, can this be measured directly or indirectly? There was an MCQ in one of the examination that filtration coefficient, it can be measured directly or indirectly. Indirectly, not directly. It is measured indirectly. How? By the calculation. It is measured indirectly, not directly. How it is? By the simple calculation of GFR upon net filtration pressure. This is around 125 ml per minute, and this is around 10 mm of Hg. So the value which you will get is around 12.5 ml per minute per mm of Hg. So this is the normal value of filtration coefficient, which cannot be measured directly but calculated indirectly. For that you must know about GFR, and you must also know about net filtration pressure. Okay, so GFR you know how to know, and NFP is calculated by 2 forces. So before entering into the net filtration pressure, let me discuss about what are the 2 different pressure. See, there are 2 types of forces. One is called as hydrostatic force or pressure. So what is difference between hydrostatic pressure and oncotic pressure? दोनों में क्या डिफरेंस होता है? What is the major difference between hydrostatic pressure and oncotic pressure. This will be discussed everywhere in the edema, in the kidney, everywhere. There are two types of pressure. The pressure which is moving the water. The pressure which is moving the water. The water is moved via hydrostatic pressure, and the pressure which is retaining the water. Retention of water. So the pressure which is moving the water and pressure which is retaining the water, there are two types of pressure. So one want to move the water, other one to retain the water, and whatever is remaining is called as net filtration pressure. Let me make a diagram for that. For example, this is your Bowman's capsule. Basement membrane is negative, and that is why proteins are repelled. I will come to that point. I will discuss in GFR about that. This is your Bowman's capsule. This is your efferent arteriole. This is your efferent arteriole, everything like that. So there are two types of pressure. So if you see over here, hydrostatic pressure of the hydrostatic pressure of the glomerular capillary. Okay, this will move the water. Oncotic pressure of glomerular capillary, this will retain the water. This will retain the water, as simple as that. Similarly, hydrostatic pressure of the Bowman's capsule will move the water, and oncotic pressure of Bowman's capsule will retain the water. Okay, so let me discuss about the values. You know what is the cause of oncotic pressure? These are the proteins. Proteins are cause of oncotic pressure, and you know that normally proteins are not filtered. So do you think how much will be oncotic pressure of this Bowman's capsule? What do you think how much will be oncotic pressure of Bowman's capsule? Because proteins are not filtered, so this will be 0. Yes or no? This will be 0. As simple as that. Because proteins are not filtered. So why this is 0? Because normally proteins are not filtered. Normally proteins are not filtered. On other hand, how much is the oncotic pressure of glomerular capillary that is preventing the filtration? It is around 18 mm of Hg. 18 mm of Hg. It is mainly because of the protein. Which protein? Mainly because of albumin. It can be because of so many proteins, but oncotic pressure is mainly because of the albumin. Now, how much is the hydrostatic pressure of the glomerular capillary? It is, you must remember these values are very important, 60 mm Hg, and this is around 32 mm of Hg. This is around 32 mm of Hg. This is a very simple calculation if you know two things. One is that hydrostatic pressure is moving the water and oncotic pressure is retaining the water. So if you see over here about the net filtration pressure, automatically you will get a formula for that. What is that formula? From here you can see hydrostatic pressure of glomerular capillary minus hydrostatic pressure of Bowman's capsule plus oncotic pressure of Bowman's capsule minus oncotic pressure of glomerular capillary. And if you put the values, it's very easy to understand. 60 minus, it's 32. It is 0 minus, how much it is? 18. So around it is 10 mm of Hg. Now in nephrotic syndrome, what do you think? Net filtration pressure will be more or less, and why? In nephrotic syndrome, you know there is proteinuria, and if there is proteinuria, this will be more than 0. This will be more than 0, and this will be comparatively less because proteins will be filtered, albumin will be filtered. So if albumin will be filtered, proteins will be filtered, it's very obvious that oncotic pressure of the glomerular capillary will decrease and of the Bowman's capsule will increase, leading to increase in the net filtration pressure. So what is the cause? Due to filtration of the protein. Due to filtration of the protein. So this is a very simple concept about how GFR is calculated. Now, one of the most important topic for the physiology is regulation of GFR. It is one of the most important topic for every examination, how your GFR is regulated. See, your BP keep on changing from 120 to 180. If you do exercise, BP will become 180, 170, 160 and 200 also. But renal plasma flow remain constant. So even though the blood pressure keep on changing ups or down, but your renal plasma flow remain constant. This is called as auto regulation. So there are so many mechanisms by which GFR can be regulated. So let me discuss about that, how GFR is regulated. Regulation of GFR, this is one of the most important topic for the not only neprophysiology but for the whole of the physiology, and a lot of MCQ come in the NEET PG in the clinical side also with this concept. Thanks Usman, thanks. Okay, so let me discuss one by one. The one is auto regulation. One is auto regulation. Yes, MCQ. Actually, initially I was doing MCQ, so a lot of students asked me to do a series on neprophysiology. A lot of students for last 3 months they are asking. That is why I arranged for this nephro series. And after finishing this theory, we will discuss the clinical neprophysiology MCQ for sure. Auto regulation. Auto regulation means simply, I told you, even if blood pressure increases, this is your BP and this is your renal plasma flow. Okay, it will initially increase, but after that this will remain constant and then increase. So from this to this range, approximately from 80 mmHg of blood pressure to 180 mm of blood pressure. So this much range is your GFR is maintained. So even if BP increases from 80 to 180, renal plasma flow will not increase, and this is called as auto regulation. And there are two mechanisms for that. There are two important mechanisms for that. One is called as myogenic, other is called as very famous tubuloglomerular feedback mechanism. Tubuloglomerular feedback mechanism. So what is auto regulation? It is automatic, like a Jaguar pump. If your hands are like this, water will come. If you pull out your hand, water will stop. So it is like something auto regulated. But there are two different auto regulation mechanism. One is called as myogenic, other is called as tubuloglomerular feedback mechanism. So let me discuss one by one. So what is myogenic? Muscle induced. For example, if this is your glomerulus, whenever there is increased blood supply, whenever there is increase in the blood supply, okay, there will be increase in the stretch. Yes or no? Whenever there is increase in the blood supply of the efferent arteriole, there will be increase in the stretch of efferent arteriole. And whenever there is increase in the stretch of efferent arteriole, there will be release of calcium. Calcium will be released. Calcium will be released, and whenever calcium is released, it causes, it is like for example GQ and spoon muscle contraction. Calcium is very important, so that will cause vasoconstriction. That will cause vasoconstriction of the afferent arteriole. So initially blood was more, causing more stretch, releasing more calcium, causing more vasoconstriction, and this will decrease the blood supply automatically. This will automatically decrease the blood supply. So you can see it's very simple mechanism. Initially there was increased blood supply, now there is decreased blood supply with a simple mechanism of stretch of afferent arteriole releasing the calcium. So calcium is acting like a ligand. So here ligand is calcium, and because muscles are involved for that stretch and all, it is called as myogenic autoregulation. It is called as myogenic autoregulation. So there are two types of autoregulation of GFR. One is myogenic, other is tubuloglomerular feedback mechanism. So let me discuss the second one. Second one is very important. There is no examination till date. That every year 1, 2, 3. I have seen in one of the NEET PG examination, there were 3 MCQ only on one mechanism, and that was tubuloglomerular feedback mechanism. I will tell you what are the MCQ asked. Question number 1. Who is the sensor here? Who is the sensor here? Sensor of TGF. Who is the sensor of TGF? Answer is macula densa. Answer is macula densa. Number 1. Number 2. What does it sense? Question number 2. What does it sense? Macula densa is a sensor. Macula densa is a sensor. So what does it sense? It senses sodium, it senses chloride, it senses sodium chloride, what? And the third question is where? Then answer is TAL. Where? Then answer is thick ascending loop of Henle. So what is the answer? It is not sodium alone. See, the first option will always will be that macula densa, whenever there is more blood supply, macula densa will sense the sodium in TAL and cause vasoconstriction of afferent arteriole. That is the wrong. Answer will be macula densa will sense sodium chloride. Not only sodium but also chloride. The second option, the third option. So they want to just confuse you. So don't get confused. It is not only sodium or chloride. It is sodium chloride in TAL. So whenever there is increased blood supply, now it's very simple to understand. Whenever there is increased blood supply, there will be more of the sodium, and this will be sensed by macula densa. Where? In the thick ascending loop of Henle. In the thick ascending loop of Henle, and adenosine will be released. So who is the ligand here? Ligand is not calcium. Ligand is not calcium. Adenosine is released from macula densa, and this will cause again the same vasoconstriction of afferent arteriole. So you can see very easily that both are almost the same, but in one sensing was different. Sensing was the stretch by the muscle, and they were causing more and more release of calcium. So calcium was the ligand over there, and here ligand is adenosine. So both are they are almost working same. That whenever there is more blood supply, there is a stretch, releases calcium, causes vasoconstriction and decreases the blood supply. Here you will see tubuloglomerular feedback. Tubule. So what is happening in the tubule? What is happening in that tubule? Sensing of the sodium chloride. By whom? By the sensor macrodensa. Then what does it do? It causes release of adenosine to cause vasoconstriction of efferent arteriole, and this will ultimately decrease the blood supply. So I have seen in one of the NEET PG examination 3 MCQ were only from this TGF. What it sense, where it sense, and one more, what it do. Okay, so I hope this is clear. These are very easy portion of neprophysiology. After that we will discuss about these syndromes and all, like Bartter, Liddle, Gitelman, and diuretics like furosemide, thiazide. So clinical importance. So nowadays they are not going to ask you very simple question. Now they are not going to ask you the factual question that who is sensed macrodensa or what is sensed by macrodensa. Now they will ask you the clinical applied. So after finishing the basic, okay, we can also start with the clinical along with that. So the first mechanism to regulate the GFR is very simple, auto regulation. Now second mechanism, third is the most important, but before third let me finish the second one. Mesangial cell. Mesangial cell, if they contract, they regulate GFR either by contraction or by relaxation. So who is going to tell me if mesangial cell contract, GFR is going to be more or less? Who is going to tell me if mesangial cell contract, GFR is going to be more or less? Just tell me. If mesangial cell contract, GFR will decrease. And if mesangial cell relax, GFR. This is also one of the latest MCQ. Okay. Now, what are the factors which are causing contraction and what are the factors that cause relaxation? So, angiotensin 2 cause contraction, so decreases the GFR. Norepinephrine, adenosine, then one more thromboxane A2, then ADH. These are going to decrease the GFR. Now, what are going to increase the GFR or relaxation? Cyclic AMP, then nitric oxide, then atrial natriuretic polypeptide, then prostaglandins, then dopamine. So these are going to cause relaxation of the mesangial cell and increases the GFR. This is very simple to understand and remember also. And the third and the most important is by changing the resistance of efferent arteriole and efferent arteriole, this will going to regulate the GFR. This is the most important one. So be very focused, very attentive. You are going to get a lot of exam question in your MBBS also and PG question also. So the third one is change in the resistance. Mnemonic is not needed. Everyone knows cyclic AMP, nitric oxide, ANP. These are vasodilator. So if you are in second year or third year or intern or post intern, you might be knowing that these all are almost working on guanylyl cyclase activity, and this is increasing the vasodilation of the smooth muscle. So of course they will cause relaxation. So if you remember this much conceptually, then that will be more helpful. So conceptually, if you remember this is going to be more helpful. Change in the resistance of efferent arteriole and efferent arteriole. This is the most important mechanism how GFR is regulated. So number one is, there can be four conditions. Number one condition can be constriction of efferent arteriole. Number one condition can be constriction of efferent arteriole. So who is causing constriction of efferent arteriole? This was question asked in NEET PG 2016. Okay, question was, in hypovolemic shock what will happen? Okay, so norepinephrine, when there is hypovolemic shock, norepinephrine will be released, causing constriction of efferent arteriole. So it's very obvious to understand, very simple to understand, that if there is constriction of efferent arteriole, what is going to happen? There will be decrease in the renal plasma flow as well as decrease in the GFR. So this happens normally in hypovolemic shock. Why? Why you need to decrease GFR and all in hypovolemic shock? Why you want to decrease all those things in hypovolemic shock? Reason being, in hypovolemic shock there is hypoperfusion and you want to divert the blood from the less vital organ like kidney to the more vital organ like brain and the heart. So that is done by causing constriction of the efferent arteriole by norepinephrine, the first. Second is dilation of the efferent arteriole. Second is dilation of, tomorrow also I will take one more session around 10 p.m. or 11, let me see, 10 p.m. or 11 p.m. whatever be the timing, I will tell you. So dilation of prostaglandin, dilation of efferent arteriole is done by prostaglandins. It is done by prostaglandins. Prostaglandins usually dilate the efferent arteriole. So if you dilate the efferent arteriole, okay, you will increase renal plasma flow as well as GFR. That is why if you give prostaglandin inhibitors like NSAIDs, painkillers, why painkillers are not good for the kidney if taken long time? Because that can inhibit prostaglandins and that can constrict efferent arteriole, decreasing GFR, hampering the blood supply of GFR, that can cause damage to the kidney. The chronic decrease in the renal plasma flow can damage the kidney by the NSAID. Now the third and the most important one is constriction of the efferent arteriole. What are the things that will happen if there is constriction? If there is constriction of the efferent arteriole. Now there are a lot of questions. For last 5 year aims, a lot of assertion, reason and all has been asked regarding this third point. I will tell you all the factors. This is your efferent arteriole and this is your efferent arteriole. Question number 1. Who caused constriction of the efferent arteriole? Efferent arteriole constriction is caused by whom? Answer is angiotensin II. Angiotensin II. Okay, so if there is constriction of the efferent arteriole, the first change that will happen is hydrostatic pressure is going to increase. Hydrostatic pressure will increase. And if hydrostatic pressure increase, eventually GFR will also increase. So eventually GFR will also increase. It's very obvious. If there is increase in hydrostatic pressure, it will cause more filtration, more GFR. for the time being, But the second factor which I am going to ask you, what is going to happen to the renal plasma flow? What is going to happen to renal plasma flow? Yes, renal plasma flow coming from the efferent arteriole. If there is constriction of the efferent arteriole, this will obviously decrease. Yes or no? Because of the back pressure. Why? Due to the back pressure. You can see here in the diagram, due to back pressure, renal plasma flow is going to decrease. And if renal plasma flow is less, so now what will happen to GFR? If even blood is not coming that much, so GFR will increase or decrease. So now GFR is going to increase or decrease? Yes, so now GFR is going to decrease. Now GFR is going to decrease. So if they ask you what will happen in the mild constriction of efferent arteriole, what is your answer? GFR will increase, and in moderate to severe, GFR will decrease. So GFR will first increase and then GFR will first increase and then decrease. First increase and then decrease. So this point should be noted here. Third is, what will happen to the filtration fraction? What will happen to the filtration fraction? You know, filtration fraction is GFR upon renal plasma flow. GFR first increases and then decreases, but renal plasma flow is always less. So denominator is always less. That is why filtration fraction is always more. So during constriction of the efferent arteriole, filtration fraction is always more. So if filtration fraction is going to be more, what do you think? Proteins will be filtered or not? Normally proteins are filtered or not? Normally proteins are filtered? No. But filtration fraction is more. So proteins will be accumulated in the glomerular capillary. Normally proteins are not filtered. However, so may be the filtration fraction, irrespective of so much filtration fraction, proteins are not filtered. So proteins will be only plasma will be filtered, proteins will be accumulated. They are repelled because of negative charge of the basement membrane and because of the size also. Okay, so they will not be filtered. So they will be accumulated. So if there is accumulation of the proteins in the glomerular capillary, what will happen to the oncotic pressure of glomerular capillary? What will happen to the oncotic pressure of glomerular capillary? AIMS MCQ. What will happen to the oncotic pressure of the glomerular capillary? Yes, of course that will increase. Why? Due to accumulation of the protein. Please write every word. Every word has been asked in your so many examination. Due to accumulation of the proteins. So every aspect of this has been asked in your Viva Voice, in your MBBS and in your PG examination. So whenever there is constriction of efferent arteriole, it is done by whom? It is done by angiotensin II. It is done by angiotensin II. and if there is constriction of the efferent arteriole, you know that hydrostatic pressure will increase. Hydrostatic pressure will increase, increasing the GFR. Increasing the GFR. Renal plasma flow will decrease due to the back pressure, decreasing the GFR. Decreasing the GFR. And filtration fraction is equal to GFR upon renal plasma flow. GFR upon renal plasma flow, and as we have discussed till now, GFR will first increase and then decrease, but renal plasma flow always decrease due to back pressure. So net resultant will be increase. So filtration fraction is going to increase. And if filtration fraction is more and proteins cannot be filtered normally from the kidney, so there will be accumulation of protein, yes or no? Yes, proteins cannot be filtered, we have discussed that. Because of the negative charge, there are solid proteins and all, so proteins cannot be filtered. So more filtration fraction will lead to more of the plasma that is filtered, and proteins will be hanging out there in the glomerular capillary, increasing the oncotic pressure. This was a recent MCQ from AIIMS. Okay, lot of assertion reason question has been asked on this concept. So if they say GFR can be increased, yes. GFR can be decreased, yes. So GFR is increased because of less renal plasma flow, no. GFR is increased due to increased hydrostatic pressure. Due to increased hydrostatic pressure. So is this much clear to everyone? I don't want to I don't want to skip any concept. If you have any doubt, you can ask me till now, because this is one of the most important topic, and a lot of people have a lot of queries about that. Yes, voice C. Any doubt, anyone? Okay, so that's nice. So this concept is clear, very good. Now the fourth is dilation of the efferent arteriole. Good. So the fourth is dilation of efferent arteriole. So who is going to cause dilation of efferent arteriole? So who is going to cause dilation of efferent arteriole? You know that constriction was because of angiotensin II. So now it's very clear that ARB, angiotensin receptor blocker, like telmisartan, olmesartan, all these sartans will cause dilation of efferent arteriole, and they will decrease GFR and increase renal plasma flow. This is good for the kidney or bad? The ARB's drug, angiotensin receptor blocker, all these sartans. See, angiotensin have effect on both efferent as well as efferent. It is not that it is only having effect on efferent, but if someone asks you more, it is having maximum effect on efferent and very less on the efferent, mainly because of norepinephrine. Okay, so this is good for the kidney. Why it is good for the kidney? It is good for the kidney. Yes, it is nephroprotective, you are correct. See, suppose that if you are very much tired, someone is having some viral infection, you want to take rest. So GFR is less, kidney is taking rest, but blood supply is high. So although you are resting, but you are taking fruits, vegetables, juice, milk and all, so that you can recover fast. So kidney is not working very much, GFR is less, but plasma flow is high. So you are not taking much work from the kidney, but you are giving the enough supply to the kidney. So renal plasma flow is good. That is why these drugs are good. That is why in diabetic nephropathy, a lot of disease, the ARBs are the first choice of the drug. We always prefer ARB nowadays, you know. In diabetic person, if there is a hypertension, we always give ARB as a first drug of choice. So these are the mechanism by which you can regulate the GFR. So till now we have discussed only one component of nephron. Till now we have discussed only one component of nephron, and that is glomerulus. Nothing more than that. Only we have finished with the glomerulus. Now I can start with the PCT today. At least we can start with the second component of the nephron, that is PCT. Okay, and we can continue tomorrow if time. Okay, 5 minutes remaining there. So I can start today and continue tomorrow 10 p.m. or 11, whatever, we can see it later on. So PCT, point number 1. So it's very sequential, very conceptual. 100% of what is absorbed from PCT, 100% reabsorption of what happened in PCT. Number 1, glucose. Glucose never pass beyond PCT because it is 100% absorbed by, I will discuss SGLT1 and 2 and blood, all those things. But first of all, remember 100% of glucose and amino acids, you know, they are building blocks, so you don't want to lose them in the urine. You don't want to lose them in the urine. So 100% reabsorption of glucose and the amino acid. And what are the substances that are absorbed? 80%. 80% absorption of, remember the mnemonic pH. P is for phosphate, H is for bicarbonate. Okay, so 80% absorption of pH and 70% absorption of what? Calcium. 70% of calcium is absorbed in the proximal convoluted tubule. 70%. Okay, and the fourth is 2/3. 2/3 of, it means 67% of absorption of like sodium chloride, then water, then potassium, lot of things are there. So these are the percentage wise. You remember, you should remember that nothing passed beyond PCT, nothing of the glucose and amino acid passed beyond the PCT. Almost 100% is reabsorbed, around 100% is reabsorbed. So this I want to put full stop here, but I want to give you a homework so that tomorrow we can start from there. I want you to study about the splay. What is splay? What is Tmax? These are your homework for tomorrow. Then what is splay? What is Tmax? What is difference between SGLT1 and SGLT2? Then what is threshold of glucose in the kidney? Renal threshold of glucose. Yes, MCQ I am preferring after finishing every topic, because MCQ is actually what I have. I want to discuss is they are integrated. Some question from PCT, some from the collecting duct. So only after finishing all the concept, then you will be able to discuss lot of MCQ. So that will be better. Let me finish first the basics, then we can discuss the integrated of MCQ. Okay, so please read about the splay and all, then read about what is Bartter syndrome. These are your homework. Then you will have doubt and I will clear tomorrow. Bartter syndrome and the diuretic like furosemide. Then what is Gentleman syndrome? What are the drugs? Thiazide. Then Liddle syndrome, and then Cone syndrome. This much is your homework. So if you do your homework and then come back, then we will interact. So that will be going to be very fruitful. Okay, Liddle, Cone, Gentleman, Bartter, Thiazide, furosemide, splay, and SGLT1, 2. All those are very hot topic nowadays. Clinically, what are the clinical feature? What is the management? What is the drug of choice? What is splay? So all this can be discussed, and then next topic is going to be very important, because today was only the briefing of the general things. Tomorrow the next session is going to be very integrated and very helpful. So I hope to meet you tomorrow also. Time it can be 10 p.m. or 11. I will make it sure that either it will be 10 p.m. or 11. Which time will suit to you? 10 or 11. So I will see to that. And those who want to join Unacademy, the code for that I have given is Physio10. Lot of batch courses are going. So you can join by Physio 10. Okay, so hope to meet you tomorrow at the same time. Till then, bye bye, good night, take care. If you like this video, please like it, share with your friend,